So now on to our keynote speaker. We were so pleased that Professor Michael Marmot was available for us because, of course, he is singular in his fame throughout the world as a distinguished epidemiologist from University College London. His work on health inequality is known worldwide. And in fact, only last week, he hit the news again because he just produced a report about the effects of COVID, let's say the unequal effects of COVID, using data that he collected in the Greater Manchester area. You might wonder, why are we having a UK epidemiologist here talking to us today? It's because Professor Marmot has always been careful to locate in a very interesting fashion his work in a European and in a global context, and we can learn and extrapolate a lot. So now I hand you over to Professor Marmot.
Us to put the issue of work in the broader context of social inequalities. I'm going to talk about British data, but I think they're entirely consistent with what we see across European countries, and where there are differences, I'll point them out. In December 2020, I produced a report called Build Back Fairer, the COVID-19 Marmot Review. And it, like all of my reports, starts with a particular point of view. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. Particularly during a pandemic, we think a great deal about the health care system, but my focus is on the conditions that make people sick. And among those conditions are, of course, conditions at work. There are other, but I'll put those in context. This is the problem that we're trying to deal with, the social gradient in health. Each of these dots represents a small area in England, classified by level of deprivation. To the right-hand end, the least deprived; to the left-hand end, the most deprived. And the top graph is life expectancy. And you can see that people near the top have shorter life expectancy than those at the top. Those in the middle have shorter life expectancy than those near the top. The social gradient in health runs all the way from top to bottom. The bottom graph is disability-free life expectancy. The social gradient is steeper. It means that people at the top are living about 12 years of their lives in disability on average, and people at the bottom are living about 20 years of their lives with disability. And here I've got pension age, which in the UK is planned to increase to 68. You can see that unless we deal with the social gradient in disability-free life expectancy, 2/3 of the population will not have disability-free life expectancy as long as 68. That may mean that they would be on disability benefits rather than pensions as the pension age increases, unless we focus on reducing the social gradient in disability-free life expectancy. A graph like that was figure 1 from the so-called Marmot Review, my review of health inequalities in England in 2010. And in 2020, just before the pandemic crashed, I produced Health Equity in England, the Marmot Review 10 years on, We look back at what had happened in the previous 10 years. And the answer was, we've lost a decade, and it shows. And this is what I mean. If we look at life expectancy for women and for men, it had been increasing about 1 year every 4 years. That's from 1980. And then in 2010, 11, there was a break in the curve. The rate of increase of life expectancy slowed dramatically and just about ground to a halt. What happened in 2010? We had a new government elected, a conservative-led coalition government. They were a bit sensitive to these figures. Surely, they said, you can't be saying that it was anything we did that might have led to this slowdown. Well, we do have to look at it. Perhaps, people said, we've just reached peak life expectancy. It's got to slow down sometime. So we looked at other countries, at the annual life expectancy improvement in weeks between 2011 and 2017. Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, Czech, all of these countries had more rapid increase than the UK. We had the slowest rate of increase of any country except Iceland and the United States. Here's the social gradient, again, in life expectancy by deciles of deprivation. The gap between the least deprived 10% and the most deprived 10% was 9.5 years for men, 7.7 years for women. And that gradient got steeper, the gap got bigger, the inequalities increased over the 10 years. And there was an interesting intersection with region. If we look at the least deprived deciles, this is women, life expectancy improved a little bit in all regions of the country, and there wasn't much difference. If we look at the most deprived 10%, life expectancy went up in London and went down, actually got worse in virtually every region outside London, and particularly in regions of the country like the Northeast and the Northwest, which were heartlands of heavy industry. And that heavy industry closed in the 1980s and 90s. And the nature of employment in those places is much diminished. And you can see that there's an intersection between deprivation and region. It's worse to be deprived in the Northeast and the Northwest than it is in London and the Southeast. And in my 2010 review, Fair Society, Healthy Lives, we had 6 domains of recommendations. Give every child the best start in life, education and lifelong learning, fair employment and good work for all, having enough money to live on, healthy and sustainable places and communities, and taking a social determinants approach to prevention. What do I mean by that? The social determinants approach to prevention. There are healthy eating guidelines. If we look at how much money it would cost to follow the healthy eating guidelines for people in the bottom 10% of household income, they would have to spend 74% of their income to eat healthily. You can see that well-paid work is a dietary issue. Food poverty is a poverty issue, an employment issue. These things are related. And what did the government do in 2010? Well, it had an ambition to roll back the state. And indeed it did. In 2009-10, 42% of GDP was public expenditure. And over the decade, that 42% became 35%. They really did roll back the state, and they did it in a regressive way. This is spending by local authority, total local authority spending per person for the least deprived 20% of areas. Their spending per person went down by 16%. And then the more deprived the area, the greater the reduction. So in the most deprived 20% of areas, the spending went down by 32%. In my 2010 review, I coined the phrase proportionate universalism. We want universalist policies with effort proportionate to need. What we've got here is effort inversely proportionate to need. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. Could this have contributed to worsening health and increased inequalities? Yeah, it could. And the model didn't work in its own terms. This is wage growth in the UK, 2007 to 2018. The only countries with worse wage growth were Greece and Mexico. Portugal and Italy were similarly bad. Then all of these other countries, European countries and the United States, had positive wage growth. So the model of austerity and cutting back on public spending didn't lead to the kind of economic recovery that they wanted it to. And the changes to the tax and benefit system had far-reaching effects. Let's look at working age families with children. If they were in the bottom 10% of household income, there was a 15% reduction in income as a result of changes made between May 2015 and June 2017. In the next decile, a 12% reduction, and then the richer the household, the less the reduction. It really did look like the Minister of Finance had a policy to make poor people poorer. Remarkably successful policy, and particularly affecting working age. So when you think about what it means to be at work, to be at that age means you're going to have children, and living conditions got worse. And the number of workers in poverty increased in the UK. Full-time employees, part-time employees, full-time self-employed, part-time self-employed. The number of workers in poverty increased. In fact, more than 50% of the people in poverty are in households where at least one adult is working. One of the things we want work to do is to get people out of poverty, and that isn't achieving its goals. And if we look at job quality index by social grade, pay and benefits, the higher the social grade, the better the pay and benefits, terms of employment, nature of work, job complexity, social support, health and well-being, work-life balance didn't show a gradient. But all of these others show a gradient. The higher the status, the better the quality of work. And then my Build Back Fairer report was published in December 2020 in light of the pandemic. Here's the social gradient in all-cause mortality. More deprived, higher mortality. And here's COVID-19 mortality. It's an identical social gradient. It means the causes of inequalities in COVID-19 are similar to the causes of inequalities in health more generally. There's some relative excess at the bottom 3 deciles for COVID-19, which, as I'll show you in a moment, we think relates to employment in frontline occupations and living in overcrowded households. And then we had the ethnic differences. One is for whites, Black African, Bangladeshi, Black Caribbean, Pakistani, astonishingly high COVID-19 mortality, and Indian to a lesser extent, males and females. More than half can be attributed to geography, where people live, crowding, deprivation, and the like, and other socioeconomic characteristics account for more than half of the excess. Interestingly, in Black African and Black Caribbean, not much of the excess can be attributed to prior ill health, although it can for Bangladeshi and Pakistani. Looking at these figures, one government minister said people from these different ethnic groups should wash their hands and practice social distancing. And I was asked what I thought, and I said, good advice, and we should deal with structural racism. And the cumulative excess mortality in the first half of 2020 was particularly high. So that's how many deaths would you have predicted from all causes based on the previous 5 years, and how many did we get? And that's the excess. In England, it was higher than in Scotland, higher than in Wales, higher than in Northern Ireland. And in the UK, the excess mortality was higher than in every other European country. It was even higher than in the United States, which was a disaster. And I asked myself the question, what's the link between what we saw before the pandemic, life expectancy stalling, inequalities increasing, and life expectancy for the poorest people falling? And that slowdown was nearly the slowest of any rich country except Iceland and the United States, and the highest excess mortality in the pandemic. Well, I think of health as a measure of societal success. If health's not improving, society is not improving. And I think the link between what was happening pre-pandemic and during the pandemic is poor governance and political culture. Social and economic inequalities increasing, reduction in spending on public services. We were ill prepared coming into the pandemic, and we weren't very healthy. And then, of course, the pandemic caused its own problems. Low-income workers were most likely to be in sectors that shut down. The COVID-19 mortality rates varied by occupation. Professional occupations, people who could work from home particularly, and here elementary occupations, caring, leisure, and other service occupations have these very high COVID-19 mortality, and similarly with women. And I talked about structural racism. If you look at occupations with high mortality from COVID-19, and the percent of the workforce that are Black, Asian, minority ethnic groups. So taxi drivers and chauffeurs, security guards, have high mortality from COVID-19, and a high proportion of their workforce is BAME. And down here, lower COVID-19 mortality and a lower proportion that are BAME. Now, we can ask the question, is the high mortality among Black, Asian, and minority ethnic groups because of their occupation? And is the high mortality from certain occupations because of a high proportion of BAME who are at higher risk for other reasons? And my guess is it's some of both. And particularly high, this is the average for all occupations, social care workers, astonishingly high. and healthcare workers. That's males and females. And for social care workers, a large proportion are in the gig economy. Fully half don't earn a living wage. But the pandemic wasn't all bad. In the USA, from March to December 2020, America's 651 billionaires had a growth in wealth of $1 trillion. You got that? $1,000 billion. Their wealth increased from 3 trillion to 4 trillion during the pandemic. There was a lot of discussion about President Biden's writing checks for $1,400 for individuals in the COVID recovery bill. These billionaires could write checks of $3,000 for each of the 330 million Americans and be as rich as they were before the pandemic started. Do you think there's some problem with this economic model? Workers in shuttered sectors, low income, losing wages, a high proportion of in-work poverty. And these guys, $1 trillion just during the pandemic. I was contacted by Lord Peter Hennessy, the historian. He said, your Build Back Fairer is a Beveridge report for our time. During World War II, in 1942, William Beveridge produced a report that laid the foundation for the British welfare state after the war. And he said, want, I'll explain that in a moment, is one only of 5 giants on the road of reconstruction, and in some way the easiest to attack. The others are disease, ignorance, squalor, and idleness. So, adapting Beveridge to my social determinants of framework, his 5 giants, disease, want is relative poverty. For example, OECD countries define poverty as less than 60% median income. So it's relative poverty. Squalor is absolute poverty. Rough sleeping. One might, at a pinch, talk about poor quality working conditions. Ignorance, lack of education, idleness, unemployment, but I would generalize that to say not just unemployment, but the quality of work, which is vital. And so in my Build Back Fairer report, building on the idea that health is a measure of societal success, I had specific recommendations relating to my 6 in my 2010 Marmot review: give every child the best start in life, education and lifelong learning, fair employment and good work for all, having enough money to lead a healthy life, healthy and sustainable places and communities, and taking a social determinants approach to prevention. But we also have to address this poor governance and political culture, the increasing social and economic inequalities, the reduction in spending on public services, and the fact that we weren't very healthy. So my general recommendation to government is to put a fair distribution of health and well-being at the heart of all government policy. I've talked about the fact that the major health problem facing the United Kingdom, and I would argue most European countries, are the inequalities in health. The fact that health improvement, which has taken place in all our countries, is most unequally distributed. And we can see not only is there an increase in inequalities in health, but in the UK, health for the poorest people has got worse. This is a terrible state of affairs. Particularly relevant to this conference is the role of work. And I think work's very important for a number of reasons. The obvious one is conditions at work can be good for health or bad for health. And that's, of course, absolutely vital. A second reason is that one of the reasons people go to work is to relieve poverty, to get enough money to live on. And if work's not doing that, there's something terribly wrong. I think work is also important in what it represents. Who does society benefit? I showed you the example of the rich people in the United States, the billionaires, who did very well out of the pandemic, thank you. $1 trillion increase in their wealth. While people who were keeping society functioning, care workers, had high mortality from COVID and are paid very poorly. I could have talked about refuse collectors, people working in supermarkets, food packers, and the like, people vital to keeping society going, the quality of whose work tends to be relatively poor. I showed you social gradients in work quality. Build Back Fairer, the title of my presentation, which was the title of my December 2020 report, should be an opportunity to rethink a great deal about society, including the nature of work and where work fits into society. Is work going to be a vehicle for some people to get enormously rich and for everybody else to earn a little bit while doing absolutely vital roles? Or is work going to be something that's meaningful to everybody, as well as safe and free from hazard? We have big questions to address if we want to build back fairer.